Chapter 14, Myocardial Infarction, and MI, also known as a heart attack. So, MIs, they involve death of your myocardial tissue. Remember back in EKG 1, we talked about the three different types of tissues. We have epi, endo, and myo. When we have a heart attack, our tissue dies. It is the third I infarction. Area is deprived of blood flow by an occlusion of a coronary artery. Remember your medical term occlusion. Occlude means to block. And remember your circulatory system, your coronary artery feeds the heart. The process is going to begin with ischemia or injury. So we are finally at the part where we are at the three I's. Ischemia, injury, and infarction. And we know that infarction, we're going to have dead heart tissue, myocardial tissue. And we know that that is a heart attack. A heart attack can be caused by the blood flow being blocked from the coronary artery. The job, the physiology, the function of our coronary artery is to feed the heart. So if our heart tissue is not being fed, then our blood flow is being blocked and we're going to have an MI. We have two types of MIs, ST elevation MI, and that is going to be transmural. ST elevation, remember we talked about in EKG 1, I had showed y'all, I was hinting to y'all what was coming in EKG 2. For ST elevation MI, that is that ST segment between the QRS and the T wave. If that segment is elevated, we could be having what's called a STEMI, which is a MI. It is usually involving the full thickness of your myocardium. Myocardium is that heart tissue. That's the middle layer. So if we are having a STEMI, it is involving the full thickness of my middle layer of heart tissue. It is a heart attack in the myocardium. A heart attack like this, a STEMI, would result in what we will see on an EKG rhythm is that ST elevation. Your T wave is going to be inverted. You can have significant Q waves. That's a really wide Q, and usually going to have symptoms of an MI. The second form of a heart attack is called a NSTEMI, a non-STEMI, non-ST elevation. If we have a non-STEMI, this is going to be the subendocardial or incomplete. It is usually only partial thickness of your myocardium. So if I'm having a STEMI, it is the full thickness of the middle layer of my heart tissue. But if I'm having a non-STEMI, it is only partial thickness of that MI, the muscle tissue, the myocardium. It is going to damage the innermost layer of the myocardium just beneath the endocardium. The endocardium, remember, is the inside. It can be difficult to diagnose. So this is what it would look like if we were just looking specifically at your heart tissue. You'll notice you see the endocardium is there in the inside, and then you have your myocardium. That first image, the STEMI, that shows thickness. The full thickness of that myocardium is damaged and is a STEMI. On the image on the right, you see your non-STEMI. That is the inner heart tissue, the inside. It's only partial of your myocardium. So a STEMI, it occurs in your myocardium, and when you're determining is it a STEMI or a non-STEMI, that depends on is it full thickness or partial thickness. If it is partial thickness, it is right below the endocardium. So what are some symptoms of an MI? The majority of us should know this, so we're just going to go over it. If your patient comes in and says that their left side chest feels tight or heavy, or they feel like there's pressure, this is a symptom of a heart attack. It can extend, that pressure, that tightness, the heaviness can extend to your chest, to your jaw, your neck, your back, and down the arm. You need to know these. So what are symptoms of an MI? Chest pain or tightness in your chest, your jaw, your neck, your back, and down the arm. Neuropathy can diminish the pain sensation. So talking about your nerves. Some people will experience this pain, but some people will not have that sensation. And women are often misdiagnosed for an MI for chest pain, which is anginal equivalent. Usually women in postmenopause will have these symptoms, and it's actually postmenopausal and not the symptoms of an MI. They will have fatigue, shortness of breath, and other vague symptoms. So this is just showing you where on the body we can have these sense of pain. Your chest, your neck and your chest and your arm, your upper abdomen, a larger area of your chest plus your neck, jaw, and then the inside of your arms, your jaw, meaning from ear to ear, your shoulders, and then between your shoulder blades on the back. Again, your symptoms could also include, besides the areas of pain, we can have a shortness of breath. You can have nausea, vomiting, pallor, meaning you're turning pale, you're white, you're losing color in your appearance, diaphoresis, arrhythmias. Remember, that is your abnormal. Whenever you see arrhythmia, abnormal rhythms. Not all patients with an MI will have all of these symptoms. So again, some of those patients, their nerves could not be sensing pain as others would. Finally, we've made it to the 3 I's that I've been talking about all semester long. These are your 3 I's of infarction, heart attack. The sequence of events, they're going to occur when a coronary artery becomes occluded. So remember, your coronary artery, that is the artery that feeds the heart, that keeps your heart alive when we're talking about the circulation system. And remember, occluded means a blockage of that artery, meaning nothing is getting through. That blockage can sometimes be damage to the tissue, and specifically your myocardium, because that is the main tissue layer where our conduction system is housed, and where we can have a STEMI or a non-STEMI. So the very first I is called ischemia. Your T waves are going to be inverted. Your tissue is starving for blood and oxygen. And your myocardial tissue, it appears to be a pale white. Okay. The second I is injury. Your tissue is injured now by the lack of perfusion, the lack of blood and oxygen. The tissue is then going to become a bluish color, and you'll have it'll be noted by an ST segment elevation. So if we are ischemia, that means my T waves are inverted, my tissue is starving at this point, and my heart tissue is going to look like a pale white color. But if I am an injury, I'm going to have an ST segment elevation. My tissue is going to appear to be like a bluish color, and I am lacking perfusion. The last one is your infarction. This is your myocardial tissue necrosis, meaning it turns black. It is noted by a significant Q wave on the EKG. Dead tissue will become scar tissue. So just to remind you, I believe I talked about it in the last presentation in chapter 13, but I talked about it a lot in EKG 1. If you put a rubber band on your finger, at first the tip of your finger is going to turn white. Eventually, the tissue where that circulation has been cut off at the tip of your finger, it's going to turn blue, and then eventually it's going to turn black. If my finger is white, I am in the ischemic phase. If I am blue, I'm in the injury phase. And if I'm black, I am infarction. I'm dead. So if my finger is white, I can hurry up and take the Band-Aid off and nothing's happened, right? My flow goes back to the tip of my finger. I go back to normal. But when I'm blue, I have an injury. I might not have great feeling at the tip of my finger anymore because that Band-Aid was on there for too long. And then if I turn black, then my finger's eventually going to fall off. It's dead tissue. There's no getting it back. We have to get it amputated. Okay, so just different ways to think of your three eyes. Again, ischemia, injury, and infarction. Ischemia is going to be white. My T waves are going to be inverted. Injury is going to be blue, and my ST segment is going to be elevated, raised, high, positive. And if I am an infarction, my tissue is going to turn black. I have dead tissue, nothing's going to get through, and I'm going to have a significant Q wave, a very big Q wave. So this is what it looks like, your three eyes. So we're going to start off. The first eye is ischemia, and then you'll notice your T wave is inverted, and we're going to have a palish color. The second phase of eyes is your injury. Notice your ST elevation. And then the third phase is infarction. We're going to have a very wide QRS. Remember your QRS, when we measure it, we're measuring where it changes the segment, where the segment becomes either positive or negative, and we're going to count as many boxes in between until the S reaches the next segment. So remember, how do you count? How do you measure your QRS? What is considered wide and what's not? Remember, your QRS should be 0.12 seconds or smaller. So your normal ST segment at the same baseline as a PR segment. So this is what we normally want to see, right? We want to see the baseline. We want to see the P wave go back to the same level as your baseline for your segment. Your QRS, the next segment is the same as your PR, your T wave. If that is all within the same, they looks like the same. If you can, a way of telling this is if you take a piece of paper and you put it up to the segment, to the baseline, and you make sure that your baseline, your ST segment, and your PR segment and your baseline are all on the same line. If somebody is elevated, then that's when we're going to notice the change. Abnormal can be elevated or depressed. So an ST elevation above the baseline, meaning it's a positive elevation, right? If we're looking at it like a number line. The ST segment elevation implies injury. Again, injury, we're going to have ST elevation, and we're going to have a bluish color, and we're going to have damage there. But we can save it. We can fix it by fixing the problem. So when maybe something's occluded and we need to put a pacemaker in. When we're talking about your ST elevation, we have two different forms of what that ST elevation can look like. So we already know that it's going to be above the baseline, it's going to be positive, but it could either be a convex shape or a concave shape. Convex is also called coved. It is most often with your STEMI in progress. So if we have a cove appearance of the ST segment and it's elevated, we are in the process of a heart attack. Concave is going to look like a U segment, and it is associated with pericarditis, but is also seen with a STEMI. So you have two forms of ST elevation. Remember, ST elevation would imply an injury, and we're on our way to an infarction. We have convex, which looks like a coved appearance, and we have concave, which looks like a U. Abnormal can be elevated or depressed. So we can have abnormal ST segments, and there can be elevated or depressed. Again, elevated is that positive, depressed is that negative. If the ST is depressed, it will be below the baseline. And this is going to imply ischemia or a reciprocal change opposite of the area of infarction. So maybe another area of the heart is infarcted, and it is showing the opposite on the opposite side of the heart. So ST segment can imply a STEMI. We're going to have elevation or depression. Elevation, your ST segment can be either concave or convex shape. ST depression could imply ischemia. ST elevation could imply injury. This is what it looks like. So your first one, that's normal, right? So if you were to put that piece of paper up and line it up with your baseline and your segment, you'll see that everything is on the same line. But if you look right next to it at convex, you'll notice your ST segment is elevated. And in this one, I'm sorry, concave. In this one, you'll notice it looks like a U. Below that is convex, and it looks like a cove, okay? And then to the left, underneath your normal segment, is ST depression, meaning your ST segment is below that baseline. Your T wave, we know your T wave needs to be normal and rounded with an amplitude of 5 in frontal leads. All abnormal T's can imply ischemia. A tall pointing T can imply hyperkalemia. Remember, we learned that towards the end of chapter 13, and I said it can be very confusing, to make sure you know your terms. Or also known as hyperacute, change of an MI in the earliest stages. So remember, right now we're looking at heart attack. You have your 3 I's, you have ischemia, you have injury, and you have infarction. If I'm ischemia, I'm going to appear to be a palish color, a white color, and my T wave is going to be inverted, but it could also be abnormal. If I'm injury, my ST segment is either going to be elevated or depressed. If it's elevated, I can be concave or convex. And if I have elevation, I could have injury. If I have depression, I can have ischemia and then infarction. If I have a tall, pointy T wave, that can indicate hyperkalemia. So this is where that phlebotomy and EKG comes in, and they kind of coincide with each other. Is now we're not just looking at your EKG rhythm for a heart attack. I can also tell if you have high potassium versus waiting for the blood work to be drawn and to be tested in the lab. I can quickly tell by an EKG. Okay, so you see here we have our normal T wave. We know what that normally looks like. And we already know what an inverted T wave, we talked about that last class. But now you're going to notice in the third image, or the second image from the top, look how pointy your T wave has become. Again, this can indicate that my patient has hyperkalemia, which is high potassium. And then we can also have a flattened T wave, so which would be considered abnormal. Also, for that normal, so you have your normal T wave, you have your inverted T wave, a tall pointing T wave, and a flattened T wave. If my T wave is inverted, if it is tall or if it is flattened, so we're not getting that round looking T wave, it is going to indicate an abnormality. And we know if it's tall and pointy, we might have hyperkalemia. Remember back to EKG 1, when we answer the 5 questions when you interpret a single rhythm. And one of the questions is, do you have T waves? Are they in uniform shape? This is what we would see if they were not in our uniform shape. They would either be inverted, tall and pointy, or flattened. All right, so we talked about ST elevation. We talked about your 3 I's. two types of heart attacks. We can have STEMI and non-STEMI. We talked about ST elevation and T wave inversion, and also the different colors and the indications of what level of an MI we are in. Now let's talk about your QRSs. A normal Q wave is going to be implying septal and right ventricular depolarization. EKG1 coming back at you, right? What is that right ventricular depolarization? Depolarization is contraction, remember. And then what is the right? What is your ventricles? That is the bottom chambers of your heart. And in this one, we're specifically talking about right ventricular. So a normal Q wave, when we're at that Q, where are we at in the heart? The right ventricular depolarization. If we have a significant Q wave, this is going to imply myocardial necrosis or necrosis. That's black, right? My tissue has become black. No impulse, no electricity can get through. So if I can't get an electric current from my conduction system into my myocardial, it's going to turn black. It's going to be dead tissue and damaged. It's going to be occluded, which can cause that heart attack. A significant Q is going to be either 0.04 seconds wide or at least 1/3 size of the R. So we are not talking about the total complex. We're only talking about that Q, okay? So your first image here shows a normal Q, right? You dip down and you go back up. Remember, your Q is going to be negative, R is positive, and then your S is negative. But look at the second image. Look at that significant Q. It's pretty wide here, right? That does not look like our normal Q or S. We're having a significant Q. So for a myocardial infarction, we're going to have a significant Q. A way to remember this is just if you can see in between the baseline, the segment and the S, if you can see a space in between, we're going to have a significant Q. But if you can't see a gap in between and the line joins into the Q, then we're going to have a normal Q. Again, if we have a significant Q, part of your QRS complex, then this can indicate infarction, which could be myocardial necrosis. Myocardial is heart tissue. The middle layer has turned black. Okay, so let's talk about the R. Your R wave progression and transition. So we're still talking about your QRS complex. Now we're specifically talking about the R, the positive deflection on an EKG rhythm. Look in your precardial leads. Remember, so we've already talked about your frontal leads, right? Remember, your frontal leads are all your leads on the front of the body. We're talking about AVR, AVL, AVF, leads 1, leads 2, leads 3, V1 through V6. Now we're going to look at the R wave. We're looking at your chest leads. And remember, this is the conduction system, how it's flowing. We start from the top of your heart to the bottom of your heart. We want to end up in the bottom left, and that's going to show where the impulse is, the contraction and the relaxation, the depolarization and the repolarization. So if we're looking at the precardial leads, this is V1 through V6. This is where the R wave starts out small, and then it becomes progressively larger in V6, and it is the tallest. So remember, in V1, we want to start off with our QRS complex having a negative deflection, and we want to wind up having a positive deflection by the time we get to V6. And we can see this transition by looking at that R wave, right? Is my R positive or is my R negative? If it's negative, do I have an R? No, I have a QS deflection. Okay. Sometimes a poor R wave will progress. Progression is only electrocardiographic evidence of an MI. So significant Q wave is going to be an evidence of an MI. Also, the color, if it's appearing black, that is an indication of an MI. But sometimes we won't have that, and all we're going to notice is that R wave progression could be the only evidence that my patient is having an MI. Maybe they're not symptomatic. They're not having chest pain. They feel fine. The transition zone of that R wave the lead in the QRS becomes isoelectric. So remember, in V3 and V4, so V1 and V2, we want to be mostly negative. V3 and V4, we want to be isoelectric, meaning we're equal on both sides of that line of the segment. And then V5 and V6, we want to be positive. It determines the heart rotation. So now we're going to talk about, you're going to have counterclockwise and clockwise rotation. Counterclockwise occurs between V1 and V2. And clockwise occurs between V5 and V6. I know this is going to be a test question on your national certification because it's too easy to get these confused. Make sure you know counterclockwise rotation is a transition happens between V1 and V2. Clockwise transition is going to happen between V5 and V6. We're talking about your R wave becoming more negative or more positive. The normal transition should happen between V3 and V4. So if it does not happen there, and if it happens in V1 and V2, we are counterclockwise. If it happens in V5 and V6, we are. So this is showing you your R wave transition. The first one, we have our normal transition. We should start off negative in V1 and end up positive in V6. We see that we become isoelectric in V4 and positive in V5 and V6. The second one shows what is the counterclockwise. This is where that transition happens in V1 and V2. So if you notice in V1 we're negative, and what happened in V2? We're already positive. There was no transition. We're counterclockwise. And then clockwise is when that transition happens in V5 and V6. We were predominantly negative, and we don't see a change until V5 and V6. We don't see a transition until 5 and 6. So make sure you know normal transition is V3 and V4, counterclockwise V1 and V2, and clockwise is V5 and V6. If I were you, I would be making my notes, because if you notice from chapter 13, there was a lot of rules and what leads to look at, right? Who should be predominantly negative? Who should be predominantly positive? Where do I look at to determine if I am having a BBB, right? A bundle branch block. Remember all of that. So now we're adding to that. Where is my transition zone? For my transmission from my R wave. If I am in V1 and V2, I am what kind of transition zone? Counterclockwise. If I'm in V5 and V6, what kind of transition zone? Clockwise. If I'm in V3 and V4, what kind of transition do I have? A normal transition. If these transition zones happen in V1 and V5, V1 and V2 or V4 and V5, this can be an indication of a MI, a heart attack. So sometimes we're not going to see ST elevation, and sometimes our patient is not going to be symptomatic. But if I see an R wave transition zone happening in counterclockwise or clockwise, this can be an indication of an MI. MI is when my myocardial tissue, my heart tissue, the middle layer becomes black, and it is necrosis. It is dead tissue. We cannot save it. If I'm in injury, I can save it. If I'm ischemic, I can save it. So, what's the evolution of a STEMI? STEMIs occur over a period of time. EKG changes are its evolution. So, for example, if you have a family history of, let's say, like my husband's family history, all the men in his family, the majority of them have died before the age of 30 from heart attacks. So it's hereditary. There's a history of heart failure on his side. They're going to, for the generations ahead of them, they're going to do constant EKG rhythms. And they're going to have a history of maybe they're yearly or annually. They come in and get their EKG. They're going to have a history of EKGs that they can look at to see if there's any signs of a STEMI or a heart attack or infarction, right? So they can occur over a period of time, and we can see when that has occurred. Your EKG changes or its evolution. So let's say you do have somebody who, let's say they had a heart attack and didn't know they had a heart attack. The way we know they had a heart attack is because their EKG is showing a STEMI over time. So depending what that STEMI looks like tells me, are they currently in a heart attack? Did their heart attack happen already? Are they starting in ischemia and they're about to have a heart attack? And we're going to be able to tell that by the evolution of the STEMI, meaning we're looking at that STEMI over a period of time. Our EKG rhythm can tell us that. So if you look here, you have immediate, so I'm on the first column for timeline, and we're going to look at the age, and we're going to have the EKG change and what implication we might have. So in the very first row, immediately before the actual MI starts, I can have my T wave is going to be inverted. What eye is this? This is ischemic. Look at the implication. Your cardiac tissue is ischemic, as evidenced by the newly inverted T wave. Meaning, I'm not having a heart attack yet, but I might be going into having a heart attack soon. Look at the second row. Within hours after the MI has started, so now I'm going into a heart attack. There's no denying it. The age of my heart attack is acute, meaning it's early. My ST is elevated, and my T wave is now upright. The acute MI has begun, and it is starting with a myocardial injury. Remember, injury is my ST elevation. Ischemic is my inverted T wave. Hours later, so I've started to have a heart attack. Within hours after the start of a heart attack, my Q is going to become significant. Remember, your Q is your negative deflection. Okay, so hours later, we're going to also be in the early stages of a heart attack. And we're going to say that ST elevation, an acute MI has begun, and it's going to start with your myocardial injury. On the third row, I'm sorry, that was after the... Okay, let me just start all over. I was interrupted. I had to stop recording and I lost my spot. So just to reiterate, the very first row, right before we have a heart attack, we're going to notice we have T wave inversion. This is going to be ischemic. We're going to have a pale whitish color. Within hours after my heart attack has begun, I am in the age of acute. The very beginning, I am showing ST elevation and my T wave is positive. Hours later, I am still in the early stages of a heart attack, but now my Q wave is going to be significant and my T wave is still going to be upright. My ST elevation is going to be upright. Some of the injured myocardial tissue has died, while other tissue remains injured. In other words, some of that tissue has already infarcted and the other ones did not. We still have time to save that person. Hours to a day or two later, I'm still in the acute age of an MI, but my ST is going to remain elevated. But notice what happened to my T wave. It has become inverted, meaning I am at least a day after the start of a heart attack. Infarction is almost complete. Some injury and ischemia persist for the infarcted edges. Now remember, we have STEMI and non-STEMI, right? STEMI is the full thickness of your myocardium, whereas non-STEMI is only partial thickness, partial tissue of your myocardium. Near the endocardium is damaged. Days to weeks later, I'm in the fourth row. Days to weeks later, in some cases, as a stage may last up to a year. We're going to be an age indeterminate, where your Q wave is going to remain significant, your T wave is going to remain inverted, but look what happened to my ST segment. It has come back down. Infarction is complete, though there is no more ischemic tissue. right? Because the T wave is still inverted, which would say I'm ischemic. But though there's no more ischemic tissue, it has either recovered or it has died. The T wave inversion is still going to persist. But I want you to notice, look at your T wave inversion for age indeterminate. This is the age of the MI. Look at that Q. It is still wide. Look at your first one for ischemic. Your Q wave is not going to be as wide. You're not going to be able to see. Okay? So, and then we're going to have weeks to months to years old. My ST elevation is pretty much back to its baseline. My T wave is back to looking normal, but my Q is going to remain wide or bigger than it should be. So that indicates that I have had a heart attack in the past. So let's say 2 years ago, I've had a heart attack. Everything else is back to normal except for my Q wave. So this is how you can tell the evolution of a STEMI, is we can tell by what your QRS, your ST segment, and your T wave look like. If I'm in the early stages of a heart attack, the only thing different is going to be my T wave is going to be inverted. But if I'm going into a heart attack, I'm going to have ST elevation, and my T wave is not going to be inverted. A couple hours later, I'm still going to have that ST elevation, but now my Q has changed. It's become wide. Days to hours later, hours to days later, my T wave inverts with the ST elevation with the wide Q. I am age determinate when my ST elevation goes back to its normal position, but my T wave has remained inverted and my Q has remained wide. And then after that, my T wave weeks to months to years later, T wave is back to normal. ST elevation, if there is none, it's back to normal, but I still have that significant Q wave. So again, this is the evolution of a STEMI. And don't forget, we can have that non-STEMI. So your different ages, right? We have acute, age indeterminate. So an MI must be determined by indicated changes present on an EKG. Your acute stage is ST elevation, 1 to 2 days old. Your age indeterminate, we're going to have that significant Q. Your baseline is almost back down for the ST segment, but your T wave is inverted and you are several days old, up to a year in some cases. Old is going to be significant Q, ST segment's back at the baseline, T wave is upright, and we're weeks to years older. So we have acute, we have age indeterminate, and we have old. These are the ages of your heart attack. This tells you what phase of the heart attack you are in. The majority of a heart attack are infarction, right? The third eye, dead tissue, necrosis, black. The infarction occurs mostly in the left ventricle. Think of your conduction system. We start in the top right atrium and we want to wind up in my left ventricle. So if I have an occlusion somewhere in between my right atrium and my left ventricle, my artery has been blocked, my coronary artery has been blocked, and I can have an infarction. And these mostly occur in the left ventricle, because where is that impulse going? To the left ventricle. The greatest oxygen demand. Remember, the physiology of our left ventricle is to pump out the newly oxygenated blood, right? We just got it from the lungs, and we're going to the aorta to go to the body. So this is our greatest oxygen demand. That's where the most oxygen is at. And is impacted more adversely by your poor coronary artery flow. Remember, that coronary artery can be occluded, which can cause an infarction or heart attack. All right, so now we're going to look at the walls of your left ventricle. Here we go with your positional terms, right? If you remember back, if you've had me for phlebotomy, we talked about anterior, posterior, inferior, superior, lateral, medial, right? Here it is back at you. You'll start to notice in the medical field, everything just connects, right? Okay. So the walls of my left ventricle, we're only talking about my left chamber. We're not talking about the entire heart. The walls of my left ventricle. The anterior wall is going to be the front wall, meaning that's front, right? What's anterior? In front of. Supplied by your left anterior descending coronary artery. You have to know this. Underline it, whatever you need to do to remember this. But your left anterior descending coronary artery feeds the anterior wall. Your inferior wall is the bottom, right? Below. Inferior is below, superior is above. Inferior is your bottom. Who feeds the bottom wall of my left ventricle? Your right coronary artery. Please, please, please sink this into memory. Again, my anterior wall, which is the front of my left ventricle, is fed by the anterior descending coronary artery. The inferior wall, which is the bottom wall of my left ventricle, is fed by my right coronary artery. But remember, your national certification, it's not going to be spelled out this simple. They want you to know what you're doing, what the heart is doing. So they're not going to spell out left anterior descending coronary artery or your right coronary artery. They're going to abbreviate it LADC or RCA. Your lateral wall is going to be the left side. So just imagine that chamber and imagine all the walls of that chamber. The front one is anterior, fed by left anterior descending coronary artery. Your inferior is the bottom wall, fed by my right coronary artery. Now we're going to look at the lateral wall, which is the left side of that left ventricle, and it is fed by the circumflex. Left circumflex, left wall of my left ventricle. And then we have the back wall, which is your posterior wall, is supplied by your right coronary artery. So my right coronary artery is going to feed the back wall of my left ventricle as well as the bottom wall of my left ventricle. The back wall is posterior, the bottom wall is inferior. My left wall is lateral, right, going away from the median line of the body. That is going to be fed by my circumflex. And my frontal wall, the anterior wall, is fed from the left anterior descending coronary artery. Remember, they'll be abbreviated. So here's what we're looking at. If we're looking at the heart, so for me, I always got to draw my heart image. Pretend this is a heart, right? We're looking at the heart. Remember that when you're looking at it, your right side is always opposite on the image. So my conduction system starts at the right atrium, and we need to go to the left atrium. When we're looking at the left ventricle, that's what we're looking at here, your left ventricle. We're going to see your posterior wall, your lateral, inferior, and anterior wall. Know who feeds who, okay? So my anterior wall, who fed that? For my lateral wall, who feeds it? Inferior and posterior, they are fed by the same artery. Who feeds it? Each of the left ventricle walls, so we're talking about all the walls in the left ventricle. Don't get that confused. We don't have two left ventricles. Each of the left ventricle walls, anterior, inferior, posterior, and lateral, can be seen with your electrodes that we put on your body when we do the procedure. Your ventricles, they depolarize from your endocardium to your epicardium. So think about that impulse. Where does that impulse originate? It originates in my myocardium, the middle layer of the tissue. My ventricles are going to depolarize when that conduction system impulse touches from the endocardium to the epicardium. The only way to look at the posterior wall is through your anterior wall. This is a test question on your national certification. So the only way to look at the posterior wall means the back wall of your left ventricle is to look through the anterior wall. So we're going to have to look through that anterior electrode, the frontal electrodes. So your inferior wall, you need to know these as well, sync them to memory. What leads am I going to look at the inferior wall? Leads 2, 3, and AVF. What leads to look at my lateral wall? V5 and 6, and 1 and AVL. What leads for anterior? I just skipped over it. It doesn't let me go back. It's going to be V1 and V2. And again, as well, how do you look at that posterior wall? We have to look through the anterior wall, which is what leads V1 and V2. Look at your rhythms, what we're looking at here. For my anterior, if I'm looking at my anterior wall, notice I have ST elevation and my T is depressed and my Q is wide. I'm having a heart attack. And look at posterior. My ST is depressed and my T wave is positive. Posterior MI. So how do we tell if we are having a heart attack? My ST is either going to be elevated or depressed. If I am elevated, remember I can have concave or convex segments. The only way to diagnose a posterior MI is to look at changes opposite those that would be seen with an anterior MI. An easy way to find a posterior MI is to turn your EKG upside down and look at the V1 and V2 from the back of the EKG. Yes, it means what it means. You're going to print your EKG. You just took it on that patient. You're going to flip your EKG printout, your paper. You're going to turn it upside down and you're going to look at, because we're looking through the anterior wall. So if I hold that rhythm upright in V1 and V2, I'm looking at the anterior wall. But posterior is opposite. So anterior is in front, posterior is behind. So for me to, if I'm looking through another lead, it's going to be backwards on the other side. So posterior V1 and V2, I'll look at the EKG upright. To see if I have a heart attack, posterior, I'm going to turn it upside down. And I think I just said that wrong. So anterior, keep your EKG rhythm printout upright. Posterior, you're going to turn it upside down to see if there is a heart attack posterior. Remember, how do you tell if there's a heart attack? ST elevation or depression. You have STEMI and you have non-STEMI. If I have ST elevation or depression, I am in the injury phase, or I could already be infarcted. It's going back to knowing your rules, knowing your age, your acute age, your age indeterminate, and your old age. Myocardial infarction locations. The STEMI is diagnosed on the EKG by indicated changes in the leads for that area. A reciprocal change means opposite. Make sure you know that term. Reciprocal means opposite. This is the change of the electricity that is opposite of the infarcted area. So MIs can extend across into other walls as well. A combination of an MI do not always involve every one of the usual leads. So we can tell you all these implications, but not every one of these implications are going to be the same for everybody. They might be only showing one. For example, that R-wave transition. So we're still talking about your left ventricle, and we're talking about the walls and their reciprocal changes. Reciprocal means opposite. So if I am seeing ST elevation in V2 to V4, I am going to see its opposite in leads 2, 3, and AVF. So let's say V2 through V4, I have ST elevation. The opposite side of the wall, right, posterior, I'm going to see depression, ST depression in leads 2, 3, and AVF. And then it goes on and tell you who feeds that wall. So this is a good way to study. Just look at this and put it into memorization. Your anterior indicates V2 to V4, and its reciprocal, its opposite is going to be 2, 3, and AVF. And it's going to be fed by, remember I said they're going to abbreviate, LAD, left anterior descending. Inferior is going to be changes in 2, 3, and AVF. Reciprocal is in 1 AVL and your V leads. And you're going to have a right coronary artery who feeds it. Lateral indicates changes in 1 AVL and V5 to V6. Reciprocal is 2, 3, and AVF. And your circumflex feeds the lateral wall. Posterior, no indicated changes because there are no leads directly on the posterior wall, right? We can only look at posterior by looking through my anterior. It is diagnosed by reciprocal changes in V1 and V2. The large array of upright T and possible ST depression. It is seen in a mirror image of your anterior MI. I want you to remember that term mirror image. If you see mirror image, just automatically think posterior wall, right? Because we're looking through the anterior wall. We have to turn it upside down. When you look in the mirror, everything's backwards, right? Same thing here. So if you read on your national certification, or if you hear somebody talking about a mirror image, we're talking about the posterior wall because it is seen through the anterior wall. It is fed by the RCA or the circumflex. The extensive anterior is sometimes called extensive anterior lateral, is indicated of changes in lead 1 AVL and V1 to V6, which means their reciprocal changes are going to be 2, 3, and AVF. The anteroseptal, we're talking about your septum, indicated changes in anterior lead. There are usually no changes, and it is fed by my LAD. So definitely put this chart to memory. Get a clean piece of paper, draw your box, and list semis, the location, which is your walls, their changes, and who feeds them. And that is the best way that you can study this, is just by writing it down. You miss something, go back and review, try and write it down from memory. Do it over and over and over and sink it into memory to where you don't even have to. It just comes naturally, your memorization. All right. We're back to our 12 lead, which is EKG 2, right? But you need to learn all the parts, just like EKG 1, you had to learn all the steps. Now we're going to look at your 12 lead. We're going to note which leads have ST elevation or a significant Q. Use the infarction squares to determine the type of infarction. So wherever we see that ST elevation or Q wave, is going to tell us what wall of the left ventricle we're looking at. What wall of the heart are we looking at? Where is that infarction? So this is another chart you need to just put into memory. So notice your 12 squares, right? And you're going to have leads 1, 2, and 3, AVR, AVL, AVF, V1, V2, V3, and V4, V5, and V6. If I see ST elevation or depression, that is the wall I'm looking at. So let's say in lead 1, I'm looking at my EKG rhythm and I see ST elevation. What wall of the heart am I looking at? I'm looking at the lateral wall of the left ventricle, the left wall, and so forth. Okay? So this 12 lead, you're seeing a anterior MI. So the only way that you're going to know this is by memorizing that chart and memorizing what walls you're looking at and what leads, and you're looking for ST elevation. So here I am seeing ST elevation in V2, V3, and V4, right? And I am seeing its opposite in leads 1, leads 2, and AVF. What I mean by this, by the opposite, is my ST segment is depressed. So I am seeing an anterior wall STEMI. Okay, so again, what you're doing is you're looking for ST elevation or depression, and yet you're looking at its reciprocal changes, its opposites. So notice in lead 1, I have ST depression, but in lead 2 and lead 3, I have ST elevation. I also have convex, right? Cove looking. Concave looks like a U. So look at AVL. You notice I am opposite of lead 1, and I have a concave ST depression. AVF, I have elevation convex. V1 and V2 and V3, V4, and V5, and I can't see V6, but I have depression there. That tells me what wall. So here you go and memorize. Here's your lateral, and here's your posterior. Here's your extensive anterior and anteroseptal, your non-STEMI. So, I always think of math when I see algorithm, but here is an algorithm. So that everything that we just talked about so far, if it's too much, you can memorize this MI chart, your algorithm, and ask yourself these questions. On a 12-lead EKG, do you see ST segment elevation and or significant Q? If you do, in what leads do you see that change? And then what wall is having a heart attack? If you do not see ST elevation or Q or significant Q waves, do you see a large R wave in V1 and 2 with an upright T and ST depression? Remember, that would be counterclockwise. If yes, posterior MI. If not, is there a wide ST depression and T wave inversion at all? If not, there's no STEMI. If there is, it could be a non-STEMI. So they want you to use your algorithm to answer these questions. So do you see ST elevation? All right. So all of that we've already discussed was just on your left side. So now we're going to talk about your right ventricular. So we were talking about your left ventricle, okay? Now we're going to talk about a right ventricle. A right ventricle is going to accompany the inferior MI at times. It occurs when the blockage to the right coronary artery system, your RCA system, is too extensive that the damage extends to the right ventricle. So the heart attack could have started and it traveled to the right side. So it started on the left and it could have traveled to the right side, or there is a blockage on the right side. It does not show up on the standard 12-lead EKG. A right-sided EKG must be done. Wait a minute, right-sided EKG must be done. What is that? So in class you learned about putting your electrodes on the left side, right? The only electrodes on my right was AVR and V1, but V2 through V6 and AVL and AVF, they were all on my left side. So now we're going to talk about if we want to see if my right ventricle has any kind of damage, the 3 I's, ischemia, injury, or infarction. We're going to have to do what's called a right-sided EKG. Literally, it is just taking your electrodes from the left side and putting them on the right side. They're still going to be the same intercostal spaces. Remember that from EKG 1. Where does V1 and V2 go? On that fourth intercostal space. Where does 3 through 6 go? On the fifth intercostal space. Okay? It is suspected when symptoms are more severe, then an inferior MI alone should be done. And this is just showing you, it's just what I said, just on your right side. So if you're in the field and you're requested to do a right-sided EKG, don't go and put those electrodes on the left side. It needs to be opposite. It needs to be reciprocal. It needs to be a mirror image on your right side. So right-sided, right ventricular infarction, which is a right-sided EKG, you're going to leave the limbs in their normal place, and you're going to move the precordial leads to the right side of the chest. The ST elevation in leads V3R to V4R. Inferior MI will be obvious. So notice when we talk about right-sided EKG and we're talking about the leads, if there is an R behind that lead, let's say you're interpreting something and it says your patient has ST elevation and leads V3R to V4R, what wall could there be an infarction? You know it's going to be right side in the inferior wall. Okay? So here's what a right-sided infarction looks like. And then you have what's called infarct imposters. So we're going to talk about your pericarditis. Do you remember this from EKG 1? So you have three tissue layers, right? Your endo, your myo, and your epic, the outside layer. But also we had the pericardium, which was that sac, that clear film around an egg, right? When you boil an egg, you have that clear film. That's the pericardial sac. Its job is to lubricate and to protect the heart so that the heart tissues don't rub up against each other and chafe. We can have what's called pericarditis. And you should know whenever you see itis, you know that is inflammation. So if I have pericarditis, I am having inflammation of my pericardium tissue of the heart, that sac surrounding the heart. The ST segment elevation may instead imply an inflammation of the pericardium. The pericardium and myocardium are just beneath it or inflamed. It causes your ST elevation that can mimic an MI. So back in the beginning of this chapter, we talked about postmenopausal women can show signs of a MI, but they're actually postmenopausal. Same thing with here. Our right-sided EKG can show signs of an inferior heart attack, but it could just be pericarditis, which is inflammation of the pericardial sac. It causes ST elevation that can mimic the MI. They tend to be concave. So they're caving under, right? Concave. And then you have convex going over. It is widespread through many leads, and it can cause chest pain, crucial and differentiate from MI. When you think of heartburn, right? If you're having heartburn, your chest hurts, right? Are you having a heart attack? No, not necessarily. You having inflammation, right? Certain foods can cause your heart to burn. So this could be just another example. If you need to think of pericarditis, think of heartburn. It can show symptoms of an MI. All right, so remember your concave and convex. When we are talking about pericarditis, if we are concave, we can see a smiley face, or we can be convex and see a frowny face. So if I have ST elevation on my right side, and it's the inferior wall, and I can show convex, it is implying, concave, it is implying pericarditis. But if I am convex, I am implying a heart attack. So early repolarization. So again, we're talking about infarct imposters, meaning what these imposters of infarction, they make it look like we're having a heart attack, but we're not. So we had anginal for women who have chest pain, who are postmenopausal. That's an infarct imposter saying it looks like she's having a heart attack, but no, she's postmenopausal. We have pericarditis where it looks like I'm having a right-sided inferior wall infarction, but it's actually concave. So I'm happy I am just having inflammation, pericarditis. We can also have early repolarization. This is another imposter that can make us believe that we might be having a heart attack. Early repolarization is a normal variant, and it's sometimes seen in young people, especially young Black males. This question is usually on the national certification, and it will ask you, it will say a statement about early repolarization. Your patient is this, and this, and then it's going to give you options, and your answer would be young Black males, right? Or it might ask you a young Black male is 30, he's come in, he's showing, he's repolarizing early. What, no, it's going to ask you, this is his symptoms, and then your answer is going to be early repolarization. So if you can remember and connect early repolarization with young Black males. It's unknown why they haven't more, but it's a fact. So just connect them automatically. Early repolarization, young Black males. It also happens in athletic, people who are really athletic as well. But this can be an indication of an MI, and it could lead into an MI. Repolarization begins so early that the ST segment appears to start before the QRS is finished. So basically that segment is on top of my QRS, just like last class in chapter 13, we talked about the T wave being on top of the QRS. Early repolarization results in a mild ST elevation that does not evolve on serial EKGs, and they look like a fish hook, so precordial leads. So you might even be given a lead on your national certification, and you're going to see that fish hook. What does fish hook mean? Early repolarization. Who is more likely to have early repolarization? Young Black males. And there's usually no symptoms. So connect your terms, just memorize. Early repolarization, young Black males, fish hook, okay, in your pre-leads. And here is your fish hook for early repolarization. So notice, look at my ST elevation. That should be happening right there. But instead, what happened? I got this little fish hook up. So I have a RQS instead of a QRS. That QS is on top of my R. I have a fish hook. And you can see it in leads in V3, V4, and V5. So what are my signs of a heart attack, of a STEMI and a non-STEMI? ST elevation or depression, and also a very wide Q. In this case, I have my Q is coming after the R, right? And it's on top of it. So do you see any ST elevation here? No, because it is on top of my QRS. It looks like a fish hook, early repolarization. That is it, I believe, for chapter 14. You're going to have practice problems, and I'm just going to leave you to it. Contact me if you need help with them. I'm already at 1 hour and 9 minutes on this recording. Start doing your practices. Ask yourself your questions. If you don't know where to start when you do these practices, go to your algorithm. And those are the questions that you are to ask to see if you have a STEMI. Also, connect this. This is your 6th step of 12 lead interpretation. So remember, your first step was the basics, and then you're going to go through your steps. This is the very 6th step of your MI interpretation. Is there an MI? What wall is having an MI? How old is that MI? And what phase, what part of the eye, the injury, the ischemia, or infarction. So I'm going to go through everything. Make sure you, oh, there is another section real quick. Complications that we can have with an MI. MI can be damaged. Your myocardium is your middle tissue layer. It can be damaged during an MI. We know that, right? It can be injury, ischemia, or infarction. It is usually some degree of heart failure that can occur. Your heart compensates by pumping more often. So if I'm pumping more often, is my blood filling in while my other chamber is contracting? No, it doesn't have no time. It's pumping so fast that the blood is not circulating. And what happens? Some of that blood is going to become stagnant and can cause a clot, which can then cause a block and an occlusion, right? Your sinus tachycardia is common for following an MI. So if I have somebody who is showing a sinus tachycardia, we need to make sure that they did not just have an MI. And also your decreased diastolic filling time. That's what I just said, the blood flowing in that chamber. There's not enough time and it can lead to cardiogenic shock. Arrhythmias are also common following an MI. So when you're looking at your rhythms, you're not just seeing if there's an abnormal rhythm, right? If there is an abnormal rhythm, we want to double check and make sure, did that patient have an MI? This is looking at that 12 lead and following your 6 steps. Ventricular fibrillation is often seen and can be fatal, which is VFib. And your myocardium, it is very irritable during and after an MI, meaning it's quivering, right? It's waiting for that relay, that flag, that impulse to come. It's irritated. Electrocardiographic complications of EMI. So these, we're going to look specifically at your anterior MI. Usually in anterior, we will have a Mobitz 2 second degree AVB. So this is all coming back from EKG 1. Remember all those rhythms you had to memorize? I said, don't forget. This is why, because when we're looking at an MI, we need to be able to know what rhythms are associated with what wall of the MI. Third degree AVB with a wide QRS, BBBs, bundle branch blocks, sinus tachy, ventricular dysrhythmias. Dysrhythmia is also known as your arrhythmia. VFib in the first hours after infarction, which is fatal. AIVR, your right bundle branch block and your left posterior hemiblock. I'm going to skip through these, but these are all complications of each wall. And what is the treatment of an MI? First of all, 12 lead EKG, right? If you go into the ER and you say, I have chest pain, what they going to do on you? An EKG. And also what they're going to do? Draw your blood. The blood work that they're going to draw for is troponin, and CPK. All suspected MIs, they're going to give what's called MONA. You need to know this, okay? It's a term very used, especially if you are working in the ER. You have a patient and they say get her MONA. She's suspected to have an MI, and that's going to be morphine, oxygen, nitro, and aspirin. MONA, make sure you know that. Patients will be started on oxygen by a nasal cannula, nitroglycerin, which dilates the arteries. Morphine is for chest pain and to treat and prevent your heart from failing. And aspirin is to chew. It helps decrease your platelet aggregation, meaning if I am shown, let's say I'm a tachycardia, my heart's going so fast, the blood is stagnant in diastole, it's sitting there, it can cause a clot. That aspirin is going to thin your blood and decrease the platelets from collecting and clotting. Treatment of a STEMI and non-STEMI differ. Non-STEMIs are treated less aggressively early on. They're antiplatelet or anticoagulant medications. They're given beta blockers and an angiogram. Treatment of a STEMI, you're going to get a cardiac catheterization for reperfusion, a stent, thrombolytics, which increases your risk of bleeding, and hospital admission. Make sure you know these, study those treatments before the next class. The next 2 chapters are medications, and that's where those 2 slides are going to come in and make sense. Here is another example of Mr. Jones's first gene. Here is his second